Hello, everyone, and welcome to today's webinar, Neurodevelopment Disorders and Behavioral Management in CdLS. My name is Deirdre Suma, and I am going to be your host today. I am part of the family service team here at the CdLS Foundation, and I'm excited to be here with you. Also is my colleague, Whitney Rinaldi, and she is going to be assisting in the question and answer portion of today's session. I am also pleased to introduce our speaker, Dr. Siddharth Srivastava. He's a pediatric neurologist at Boston Children's, and he is also a clinical advisory board for the CdLS Foundation. Some of you may have met him actually in the past at one of our conferences or potentially at our adolescent and adult clinic in Baltimore, Maryland. Before I hand the mic over to Dr. Srivastava, I just wanted to go over a couple housekeeping items with you. First, I wanted to let you know that today's webinar will be made available on demand after today's session. And also, we will have it uploaded to our website in case you want to go back and review some of the information that is presented today. Next, during this presentation, we would love to hear from you. If you look over to the right of your screen, there is a questions tab. And if you click on the arrow, you can type in your questions and submit them to us. So maybe right now, if you guys can take just a minute and go over to the question tab and let us know where you're calling in from, that would be great. While you're doing that, I also wanted to just let you know that the questions that you're going to be submitting throughout the presentation today is going to be addressed at the end. If by chance we are unable to address all the questions submitted, we invite you to go to our website, and under the Ask the Expert form, you can fill that in, and then we can certainly forward those questions over. So at this time, I would like to welcome Dr. Srivastava and thank him for sharing his time with us today. Thank you.
Great. Thank you so much for that introduction. So today I'm going to be talking about the medical management and neurodevelopmental concerns in CdLS. I don't have time to touch base on every aspect of things, but I'm happy to answer questions at the end and talk offline in more detail. So here is an outline of my talk. I'll present some background information. Next, I'll talk about language disorders, attention deficit hyperactivity disorder or ADHD, anxiety and depression, and aggression and self-injury. And then I'll wrap the talk up with some conclusions. So before I proceed further, just some general messages. So keep in mind that non-medications can be effective and are effective, but I'll try to focus this talk more on the medications aspect of things. The information I'm going to talk about is a combination of anecdotal data, information I gather from patients, observational data, and also extrapolated data from other neurodevelopmental disorders. But it goes with that saying that in general, there's a great need for a lot of evidence-based research on neurobehavioral interventions in CdLS, and I'll address that at the end of the talk. So first, some basic background information. So as you know, features, intellectual disability, autism spectrum disorder, multiple systemic features. Behavioral features can include hyperactivity or ADHD-like features, aggression, anxiety, depression, just to mention a few of the many types of different behavioral issues that can occur. Now, why is it important to address challenging behaviors and developmental concerns? Well, the answer is pretty simple, pretty easy. These are issues that affect quality of life for affected individuals, for their family members, and addressing these concerns at an early stage, whether that's through a medication, through a therapy, through some other type of intervention, that has the potential to potentially improve long-term outcomes. So let me spend a few slides just to talk a little bit about development, because I think it's important for understanding this talk. So when I talk about development, what do I mean? So child development refers to a timed, ordered series of events or milestones that take place, affecting domains such as motor skills, language, socialization, and cognition or thinking skills. Neurodevelopmental disorders are disorders that affect each of these domains in certain ways. And it's really important to know that these are just descriptions. For example, significant motor impairment is characterized by the term cerebral palsy. Significant language impairment is characterized by the term language disorder. Language and social impairment can be characterized by the term autism, and cognitive impairment is characterized by the term intellectual disability. Behavioral problems can result in symptoms of ADHD, anxiety, depression, aggression, and self-injury, and so forth. Of course, this is a huge oversimplification, but I think you get the idea. And in CdLS, the full spectrum of neurodevelopmental disabilities can occur. And the ones with the star listed on the slides are the ones I'm going to focus on in my talk. So language is quite important because language is the primary way with how we interface or interact with the world. And I like to think of language as having two components, an expressive component and a receptive component. Expressive language is our ability to communicate thoughts and ideas. And receptive language, in contrast, is our ability to understand thoughts and ideas. And on one level, receptive language is very similar or can be quite similar to thinking skills or cognition. Now, it's important to view language in the context of cognition or thinking skills. So look on the graph on the left. So let's say you have a 6-year-old child who has an IQ of 50. So the way to interpret that is as follows. So you take the age, 6 years old, and you multiply by the IQ converted into a percentage. So if you multiply 50% times 6, you get 3 years of age. So a child who is 6, who has an IQ of 50, has the thinking skills of a 3-year-old, and similarly has a language skills of a 3-year-old as well. So if you look on the graph on the right, so this is a contrast scenario. So this is if you have language that's disproportionately affected compared to thinking skills, then you're dealing with not only intellectual disability, but a superimposed language disorder. So for example, if you have a 6-year-old child whose IQ is 50, but because there's a superimposed language disorder, their language abilities are much less than that of a 3-year-old level. Language disorders reflect our impaired ability to communicate, and this can be a common challenge for individuals with CdLS. I like to think of a couple of different pillars of treatment for language disorders. So there's one-on-one speech or language therapy. There's play or social groups, which is where children learn to model language and socialization from each other. And there's also augmentative and alternative communication. Augmentative alternative communication, or AAC, is the use of special devices that allow children to communicate in the absence of spoken language. So these devices can be high-tech, such as the mountable electronic device that you see, or they can be low-tech, such as a handmade picture board. And AAC is really, really important for children, especially children who are nonverbal. And I know this is not a medication per se, but it's a great intervention, and I recommend families look into it because it may unlock some potential to communicate. And I think that's really, really important. So let's switch gears a little bit and talk about attention deficit hyperactivity disorder, or ADHD. So this is a common feature of neurodevelopmental disorders, and CdLS is certainly no exception. So ADHD is a disorder that's associated with inattention, hyperactivity, easy distractibility, and impulsivity. And these symptoms have to occur in multiple settings, 2 or more settings, such as the home or the school, and they have to be functionally impairing. There are 2 approaches to treatment, and often both are necessary. A non-medication approach involves behavioral therapy, and the purpose of behavioral therapy is actually more for the families, more for the parents and caretakers to give them strategies to redirect a child's behavior. If behavioral therapy is not effective, then medications may be necessary. And then there are a couple of 3 different classes of ADHD medications. There's methylphenidate products, which are stimulants. There's dextroamphetamine products, which are also stimulants. And then there are non-stimulant medications. Treatment may require a trial and error approach, starting with one class of medications and switching to another because of perhaps poor response or side effects. I recommend a start low and go slow approach, especially because the metabolism of kids with CdLS may be different. And you may get side effects that you might otherwise not expect. The main side effects of stimulant medications, of ADHD medications, include decreased appetite and disrupted sleep. But both of these challenges have solutions, meaning you don't have to give up on a medication just because of these side effects. There are ways around them. And I think it's important to wait at least 1 week before deciding whether a change in dose of a medication or a change in medication is effective or not for ADHD. I really would recommend avoiding the temptation to stop a medication early unless there are serious side effects. And the reason being is that it's really good to have a full week's worth of data to see, is a dose change or is a medication change truly effective or not. Choosing which medication depends on your preference for duration of medication and how your child can take medications. So within each class of medication, there are some short-acting forms, which last 3 to 6 hours or so. There are long-acting forms, which last 7 to 12 hours or so. And then sometimes there can be pill options, which you can't crush or chew. There can be capsule options in which you can open up the capsule and sprinkle it onto food. There are some chewable forms, chewable pills. There are some liquid solutions, and there are even patches that you can apply onto the skin. So I'm going to present an algorithm that's just one example of an approach that you could take for treatment of ADHD and CdLS. And so I'm going to close close this just so you have a better idea of this algorithm. So the first step of any kind of behavioral algorithm or flowchart is just to make sure, are there any addressable medical or environmental factors which may be preceding the behavior? Because these are things that may be treatable or addressable. Let me see if I can do laser pointing here. Okay. So the first step I usually start with in terms of medication. So I usually start with a stimulant, usually a short-acting methylphenidate product, such as methylene. And it's really important to make sure that the dose is optimized, because sometimes the dose may be too low and it may be perceived that there's not really effect, but it's just that the dose is not high enough. So if there's a good response, of course, you continue that medication. But if there's a partial or non-response, meaning that the response to that medication that you tried first off is not great, then the next step I usually go to is this follows. So I'll switch to a stimulant that belongs to a different family as what I tried previously. So if I started with a methylphenidate product, such as methylene, I might switch to an amphetamine product, such as Adderall. And once again, I make sure to optimize the dose of this medication. So if the response is good, continue this medication. But if the response is suboptimal, meaning it's not as good as we would like, then I consider switching to what's known as an alpha agonist medication. And examples of this class of medications is guanfacine or clonidine. So again, seeing what the response is. If it's good, we continue that medication. But if there's a partial or non-response, then I consider switching to a medication called atomoxetine. The key thing to know about this medication is that you have to be able to swallow pills whole, which can, of course, be a challenge for some individuals. So if the response to this is not great, then you can consider doing a combination of medications. So you can consider a stimulant such as methylphenidate or Adderall plus an alpha agonist medication such as guanfacine or clonidine, or you can consider a stimulant such as a methylphenidate product or amphetamine product plus atomoxetine. Now, once again, if the response is great or good, continue that. But if the response is not great, then at this point, other options you can try could be, well, trying another medication from a family that you've already tried before, but a different formulation. And as I mentioned before, sometimes it can take a trial and error approach to decide which is the right medication at the right dose. One of the things to mention in this flow chart or in this algorithm is that I started with a stimulant medication, although sometimes, and depending on the age and depending on the circumstances, you could start with an alpha agonist medication like clonidine or guanfacine, especially if the child is young. Okay, so next I wanted to talk a little bit about anxiety and depression, which certainly could be challenges faced by an individual with CdLS. A couple of things to note about anxiety and depression. So these can have a variety of presentations in children with CdLS. Symptoms can include irritability, excessive worry, perseveration, social avoidance. And sometimes it can be really difficult to recognize anxiety and depression, especially because there can be increasing levels of cognitive impairment or intellectual disability associated with CdLS. As with ADHD, there are two approaches to treatment. There's a non-medication approach, which involves seeing if there are any triggers for the anxiety and depression. A specific type of behavioral therapy called cognitive behavioral therapy can be useful for anxiety, but once again, this depends on having a certain cognitive ability to participate in this kind of therapy. So often medications can be necessary, and I've listed three broad categories of medications that are used for anxiety and depression: selective serotonin reuptake inhibitors, other antidepressants, and even a class of medications called benzodiazepines. SSRIs, or selective serotonin reuptake inhibitors, so these are often first-line treatments for anxiety and depression. An SSRI may help anxiety and mood states in CdLS, but one caveat to mention is that it can sometimes, in some circumstances, SSRIs can lead to worsening agitation, and that may be dose-related. In general, I tend to discourage the use of standing benzodiazepines for management of anxiety because there's a risk for physiological dependence and even paradoxical agitation, meaning that you give the medication to make things calmer, but you get an opposite reaction. You get a child who may be revved up and agitated. So here I'm going to talk, as with ADHD, I'm going to present just one example of one approach to treating anxiety and depression in CdLS. Keep in mind that this is just one example. It's not kind of the definitive approach. And of course, as I mentioned before, there's really a great need for evidence-based treatment recommendations for all of these different indications in CdLS. But I'll present one of the approaches that you could consider for treatment of anxiety and depression in CdLS. So as said before, it's really important to rule out any medical, environmental, or other factors which may be contributing to the behavior, like anxiety in the context of a specific trigger or specific environment. Assuming that's not the case, that there aren't any addressable medical, environmental, or other factors, So I usually start with an SSRI medication at a optimized, once again, at a low dose, but optimized dose. The medications I tend to start with, so one of the following, so either fluoxetine or sertraline or even fluvoxamine. Though you could consider other SSRIs such as escitalopram or paroxetine. But I usually start with one of the first three I mentioned, either fluoxetine, sertraline, or fluvoxamine. Once again, if there's a good response, I would continue it. But if the response is not great or there's a suboptimal response, the next step could be switching to another SSRI. So if you tried one of the SSRIs in the first step, then try a different SSRI that I've listed in the box below. So once again, assessing response. If the response is good, we'll continue. But if there's not a great response, then I might consider switching to a different class of medications. This is a class of medications called an SNRI, but examples include venlafaxine or duloxetine. And once again, making sure the dose is starting at a low dose, but an optimized dose. If the response is good, we continue it. But if the response is not great or suboptimal, then the next step could be considering a medication like buspirone either alone or in conjunction with another of the medications that I listed above. So either by itself or as an adjunct medication in combination with others. If the response is good, then we continue it. But if the response is not optimal, then once again, as with before, it might take some trying a different SSRI, trying a different SNRI, or trying other combinations of meds, such as the buspirone plus an SSRI or something of that sort. As with all of these, it's especially with the complex behavioral needs for individuals with CdLS, it's often good to have psychiatry input and work together as a team to come up with the best game plan. So the last kind of big area I wanted to talk to you about is aggression and self-injury, which of course can be quite challenging for some individuals with CdLS. These examples of aggressive self-injurious behavior include things like head banging, hand biting, excessive scratching, and so forth. And understandably, these can be a source of tremendous parental distress. These behaviors require a full behavioral assessment in order to identify triggers. The reason being is that if there's a specific trigger for the aggression, and that trigger can be a medical problem like reflux, dental issues, such as cavities, skin ulcers, then the treatment, of course, will address the underlying medical issue. Or if there's a specific environmental factor that's contributing to the aggression, then that's where the functional behavioral assessment may be important to identify what is a trigger of these behaviors so that you can remove that trigger and reduce the behaviors. Now, in terms of medications for aggression in CdLS, there's a class of medications called neuroleptics that may be an option, specifically second-generation neuroleptics. So risperidone is a prime example of this, and that might be an option for CdLS. Other second-generation neuroleptics to consider include aripiprazole, quetiapine, and olanzapine. In some cases, you may need a mood stabilizer, such as a seizure medication called valproate, or a medication like lithium to be helpful, but data in general is limited. One caveat to mention about neuroleptic medications, so these are potent, strong medications. So there's a potential for serious side effects, such as metabolic syndrome and weight gain, so affecting things like cholesterol levels, sugar levels, and so forth. here is my general approach to treatment of aggression in CdLS. And once again, I'm just mentioning it's one example of an approach. There are many different types of approaches. And like I stated before, it would be good to come up with kind of consensus-based guidelines. But for the time being, I'll go through how I tend to view things, and I'm open to kind of feedback at the end about other people's approaches. So as I stated before, the first step is, of course, making sure that you've identified any medical, environmental factors which may be treatable or addressable. Assuming that's not the case. The first step I usually take is starting a class of medications called alpha agonists. So these are the same class of medications that have been used for treatment of ADHD. So this class of medications includes things like clonidine and guanfacine, once again at an optimized dose. So the next step, assessing response. Is it a good response? We continue. But if the response to this medication is not great, if it's a partial or non-response, the next step is I consider switching to actually an anti-seizure medication that has mood stabilizing properties. So examples of this include things like valproic acid, lamotrigine, carbamazepine, or oxcarbamazepine. The thing to know about these medications is that you do need periodic monitoring, which involves blood work to make sure the levels are okay, to make sure there are no effects on liver function or blood or chemistries or blood cell counts. So that's just one caveat to mention. So we assess for response, and if the response is good, we continue. But if the response is not as great, my next step is to consider switching to the neuroleptic, to a medication from the neuroleptic family. So I mentioned some of these examples. So risperidone, aripiprazole, quetiapine, olanzapine, ziprasidone. So these are a couple of different examples. You may have to try one medication from this family and switch to another if there's not great effect. So once again, let's say you've tried a couple of different members from the neuroleptic family and there's still not a great response. One possible next step is to kind of consider a trial of a benzodiazepine medication, such as clonazepam or lorazepam. Once again, kind of my preference is I generally tend to kind of avoid these class of medications, but will use it if necessary, if the aggression is quite severe, quite serious. If the response to this is still not great, then you can consider alternative and adjunctive medications. So I've listed a couple of these examples over here. So gabapentin, propranolol, antihistamines, a medication called N-acetylcysteine, baclofen. So these are medications that are used for various other reasons. So gabapentin is often used for neuropathic pain. Propranolol can be used for migraines or headaches. N-acetylcysteine can be used for skin picking or trichotillomania. Baclofen is actually a tone medication used for spasticity. But there's limited and case reports and some small data to suggest that some of these medications may be helpful for aggression, especially when you've used a lot of other different typical medications used for aggression. So once again, we assess for response, and if the response is still not great, then you could consider a mood stabilizer such as lithium or more potent neuroleptic such as clozapine. I tend to kind of save these medications as a last resort because they're pretty potent medications. And if you're at this step, certainly there should be psychiatry input involved, and preferably from an early stage as well. Once again, the general approach is kind of going from least for a tendency for lower side effects and going kind of down the line to more potential for more and more side effects. And once again, if the response is still not great, then kind of considering additional out-of-the-box solutions, combinations of different medications, trying other of these alternative adjunctive medications, and reevaluating from there. So I'll just wrap things up with some general conclusions. So there's a spectrum of neurodevelopmental disorders associated with CdLS, ranging from autism, intellectual disability, language disorders, ADHD, anxiety, depression, self-injury, aggression, and so forth. And it's important to see what the core behavioral symptoms are to be able to target the medications to those core behavioral symptoms. And I've alluded to this many times in this talk, but there's a great need to study what medications work and what medications don't work for individuals with CdLS, because every child, every individual can have a different metabolism. Each child can have side effects that you might not typically expect for that class of medications, and so forth. So lastly, just to end things on some acknowledgments. So of course, I'd like to acknowledge the families, the CdLS Foundation. They're the reasons why clinicians why we do the things that we do. We're really motivated to help you guys out, and we really learn so much from the families and the individuals who are affected. Like to thank Dr. Marva Grados, who's my mentor at Hopkins, who I worked for under several years and learned a lot from. Dr. Alex Kalevzon, who is a child psychiatrist at Mount Sinai. He's worked on several different algorithms for behavior and Phelan-McDermid syndrome, and specifically on a project called Project Echo. And I drew inspiration from some of the work that he's done. And just lastly, to my mentor at Boston Children's, Dr. Sahin, who works in the Transitional Neuroscience Center and working on different clinical trials for different neurogenetic and neurodevelopmental disorders. Thank you. I guess I'll open it up to questions now.
Okay, thank you so much, Dr. Srivastava. Our first question is, in the general approach to treatment in ADHD, specifically with CdLS, are there any non-medication approaches considered, like vitamins?
So that's a great question. So so far the evidence is not great, or not terribly supportive for the use of things like diet or certain types of like fatty acids. Virin is an example. So far the evidence does not, or there isn't great evidence to support efficacy for ADHD in general, and much less for CdLS specifically. So I tend not to, I think it's okay to do trials of those things, because the downside is minimal. If it's a multivitamin or if it's a supplement that has minimal side effects, then I think there's not a harm per se in doing a trial of those supplements. But the evidence so far doesn't support efficacy for those.
Great, thank you. Our next question is, how do you suggest I begin the process if I feel medication may be the path for my child? Where should I start?
Absolutely. So that's a great question. So it begins with, I think, I think the first step is to kind of see if you are close to a tertiary care center where you have expertise in child psychiatry, in developmental medicine, in someone who's trained in neurodevelopmental disorders or child psychiatry. I think that's the first step. Sometimes pediatricians, general pediatricians, do feel comfortable starting medications, but in many cases, a pediatrician may not feel comfortable doing so. So the first step is to see, is there someone within, someone who's trained in child psychiatry or neurodevelopmental disorders, a field called NDD, neurodevelopmental disorders. I think that would be the next step, and they would be able to work with you to help come up with a game plan. And I'm happy to, if you're in touch with me by email, I'm happy to kind of direct you, which will be specific to where you live and so forth.
Great, thank you. Our next question. What is your knowledge of the effectiveness of applied behavioral analysis on the behaviors associated with CdLS?
Absolutely. So there's good data for use of ABA in children with autism. in children with autism, ABA is proven to be effective in improving adaptive skills and social skills and communication skills, especially if you do the intervention early and do intensive support and services at an early age. Now we know that many individuals with CdLS have autism, and the fact is ABA, even though it's approved for children with autism, ABA can be helpful for individuals with intellectual disability and communication disorders and so forth. So in general, I think it's a good intervention. So especially if your child has autism, it can be very difficult to get insurance to approve ABA therapy if you don't have a diagnosis of autism, though. So unfortunately, we're limited in that circumstance, although just from a principle standpoint, it may be effective for individuals with intellectual disability and other neurodevelopmental disorders.
Great, thank you. Some parents say that hand biting or scratching is typical behavior that happens sometimes. When does it get to the point when treatment should be considered?
Right. I think so. Regarding hand biting and scratching, I think the first thing is to kind of look for simple solutions. So, is the skin dry? Is there something bothering the child about the skin itself? During winter time, the skin can be dry, and maybe there's some scratching, biting due to some simple things like that. The next thing is to ask yourself, could there be any kind of medical reasons why there may be kind of, skin biting? I mean, even though, could there be reflux, or could there be something like that? Even though it may not make sense, why is a child biting their hand if they're having reflux? Well, if your child has limited abilities to communicate and they're frustrated and they're in pain and they're not having a great time, and this may be a way, if they're having something that's undiagnosed, a medical condition that's undiagnosed, then this behavior just may be an expression of discomfort. So I think I emphasized that a couple of times in my point, but I think I'll underscore it again too, just making sure you're looking for medical reasons like dental issues, ear issues, headaches, reflux, and so forth. Next step is, sometimes you can do non-medication approaches, such as like, wrist splints and gloves and things like that, which occupational therapy and occupational therapists may be able to help you with. Sometimes having a device like that, like a splint or a glove or something of that sort, may be enough to extinguish the behavior. But to get to what you're asking about, I think if you feel like the behavior is causing an impact in comfort or function, or causing like any, certainly any organ damage or any kind of major injury, I think that's the point. So the key point is I consider medications if there's functional impairment, and that functional impairment can be, well, it's the child is doing it so much, it's interfering with how that child is able to participate in school or at home, or the child is doing it so much that it's causing like bleeding or causing skin breakdown or causing infections, or it's causing so much distress to the child or even just to the household. So those are some reasons to kind of start to think about medications for that kind of behavior.
Great, thank you. The next question. My daughter is 24 years old and has shown worsening symptoms associated with autism. For example, repetitive behaviors, increased sensitivity to sound, reluctance to interact with others. Is there any proven behavioral therapy or medications? She's currently on Lexapro.
Well, so I think the first step is to kind of identify what could be the cause of this regression. So typically with just, once again, we're speaking with respect to autism, and there can be an autistic regression early on. In CdLS, there can be regressions of the type that you mentioned. And I think in my mind, the first thing I would ask is, well, could the regression actually could this be a symptom of like an untreated, anxiety or depression or something of that sort? There isn't so I would kind of explore along those lines, and it obviously will be limited by the individual's ability to communicate or not. But as I mentioned to earlier, in individuals with intellectual disability and in individuals who have decreased ability to communicate effectively, diagnosing anxiety and depression can be difficult, and sometimes it may go under the radar. But there's no specific medication per se that is indicated along those lines. In other syndromes, so in one genetic syndrome that's unrelated, some people are looking at the use of a medication called olanzapine to target regression that happens in adolescence. That's associated with other features, but once again, it's a different genetic syndrome. And I think we don't know a specific, at this point, we don't know a specific intervention or medication for that circumstance that you described, but I would encourage kind of exploring, could this be under-recognized, or could this be a manifestation of anxiety, depression, or something of that along those lines?
Great, thank you. Next question. Has there been any success with cannabis and CdLS as associated with autism?
Yeah. Once again, a great question. So there's a lot. So the short answer is it's not clear. I think it needs to be studied, and there's no data yet to support its use. But I will say there's a lot of interest about use of CBD cannabinoid, derivatives in autism in general, and in other neurodevelopmental disorders. So right now, CBD is approved for use in certain epilepsy syndromes like Dravet syndrome. And researchers are looking into the use of this in autism and other neurodevelopmental disorders. So for CdLS, there's no data yet on its efficacy. It needs to be, I think it needs to be, it's something that should be studied. Sometimes families on their own may go out and try CBD oil for their children, to targeting anxiety or targeting ADHD type symptoms or other types of neurobehavioral symptoms, which is okay. The only thing I will say is that CBD can interact with the levels of other medications, including anti-seizure medications. So especially if your child is on a seizure medication and you decide to do an empiric trial with CBD oil, just to make sure that the levels of the other medications are being monitored closely, because it can reduce or elevate levels of anti-seizure drugs, which can affect seizure control.
Great, thank you. Next question. My son is 29 years old with an IQ of 80 and communicative, eloped 2 years ago. On foot, and then again 2 more times, and obviously was in danger. I'm sorry, I'm not seeing the question in there. This is from Jody. If Jody, can you resend me that question? I'm sorry, I can't happen to find where that question is. So we're going to move on to the next. Oh, okay. Go ahead. Sorry.
Well, I think if I could perhaps kind of guess. I'll talk a little bit about that situation, elopement. So elopement, and pardon me if it doesn't apply exactly to your child's circumstance, but elopement is something that can be a challenge. Elopement meaning child or individual running away from the family member, or causing safety concerns and causing distress. There's a variety of tools that you can do. So the autism, one of the autism foundations has like what they call a big red safety toolkit, which is a checklist of things that family members can do beforehand to things like making sure the local police, making sure seeing if and a variety of different things along those lines. There are bracelets and GPS trackers, that go onto your wrist or your ankles, and a variety of other devices that you can consider if elopement is a concern and you're worried that, oh, what if my child runs away? What can I do? So once again, feel free to connect with me by email, and I can refer you to a variety of resources that can be helpful for if elopement happens, what to do next, or to prevent, or to kind of prepare yourself.
Great, thank you. The next one is not a question, but they wanted to share about medications. So it
Great.
says, just wanted to share that my daughter is 28 years old and has had seizure disorder, tonic-clonic since birth. Around 10, she was able to wean off medication, in parentheses, Keppra liquid. But at the beginning of her teen years, she started seizures again, but then were more focal seizures. She has had anxiety and self-injury and was on medication for that. Over time, she was able to work with behavioral plans to help with behaviors. She has found over the past couple of years that the Keppra liquid at 3 teaspoons twice a day for 1,500 milliliters twice a day was causing her behaviors like depression, anxiety, and aggression. We worked with weaning her down on the Keppra to 3 teaspoons at bedtime, 15 milliliters once a day, and has added Lexapro at 7.5 milligrams once a day, and have found the balance for her. It has made her more even, lessened her anxieties, and she is more pleasant, and her seizures are controlled. Thank you, Shirley, for sharing that.
Great. And if I could comment a little bit about that, once again, thank you for sharing that information. Keppra is a seizure medication, also known as levetiracetam. One of the side effects of Keppra can be behavioral agitation, so or a lot of irritability. It can be addressed as you've done by either lowering the dose. Sometimes you can also add vitamin B6 or pyridoxine, which can sometimes alleviate the symptoms of irritability associated with Keppra. So that's also another option. And just also speaking generally to if behavioral issues are a concern and there's also seizures that are concerned, then it might be worthwhile to consider a medication like that I listed in my talk that could potentially address aggression and also seizures, so things like Depakote or Trileptal, but those are all obviously dependent on the specific epilepsy circumstances and depending on the specific clinical circumstances, but just some general information.
Great, thanks. Next question. How do you identify the difference between behavior versus a seizure?
Yeah, so that comes up a lot. So I think so in terms of seizures, so there are some types of seizures that are pretty not subtle, meaning that you know that a seizure is happening. So these are like rhythmic movements of the face, arms, legs that are not suppressible, meaning that if you put your hand on them, they still persist. Sometimes there can be more subtle spells that are a little bit difficult to know if they're a seizure or not. So for example, staring spells are something that can happen. So staring spells can look like daydreaming spells, but one question is, well, could these be seizures or not? And what I suggest is if there's a staring spell that's happening, really trying to see if you can get that child's attention. And by that I mean kind of doing almost obnoxious maneuvers like blowing in the child's face or tickling their nose or really like calling them loudly, shaking their hand, and really trying to see if these almost obnoxious measures are causing any change in state. If they are not, meaning that in spite of doing these obnoxious measures, the child is still kind of staring ahead or doing the behavior, I think it raises more of a concern for seizure. Once again, the gold standard for diagnosis of a seizure is having an electroencephalogram or a brainwave test on while the child is having a spell, which sometimes it's hard to do. What I tell families is that if your child is having some sort of behavior that is you're not quite sure if it's a seizure or not, then take a video and send it to the neurologist or send it to a specialist who can take a look and better interpret that. So when in doubt, take a video of the behavior because I think the neurologist may take a video and see or appreciate some things that are subtle that are not quite picked up on verbal description. So yeah, that's what I would suggest.
Great, thank you. Next question. how would you suggest approaching possible behavior approaches? However, my child cannot speak.
Right. I think the first thing is to really, I think the first thing is, and this can be done parallel to behavioral approaches, make sure there's some sort of augmentative alternative communication program or evaluation for that. The reason being is that sometimes frustration at inability to communicate can be a source of the behavior itself. Like if you're let's say you don't have the expressive speech, but receptively your understanding is much better than what your verbal abilities suggest, then you want to communicate, you want to express your needs, but you have difficulty doing so, and then you can become frustrated, and you can become aggressive or look hyperactive or inattentive and so forth. So the first suggestion is, well, if there isn't an evaluation done for some sort of augmentative AAC program like a PEC system or iPad with communication program or something of that sort, I would encourage that to happen. And then simultaneously, or maybe after the communication evaluation, then work on consider. So if you have a child who has a diagnosis of autism who would be eligible for ABA therapy, the BCBA, the behavioral analyst, may be able to help work with the child in reducing those behaviors. Or if you can get a behavioralist involved, get your insurance to have a behavioralist, get insurance covered for a behavioralist, that would be great as well, to kind of see if you can address the behavior with behavioral approaches with either BCBA or something of that sort. And then only the next would I kind of think about medications, meaning in spite of optimizing communication or working on communication, and in spite of working with a behavioralist for a good period of time. And also keep in mind, it can take months, a long time, before you start to see a response. But let's say you have a communication program going, and the child does see a behavioral therapist regularly for a good period of time, and the behaviors are still happening, then consider medications, and then once again targeting the type of symptoms that you're seeing.
Great, thank you. Next question. My son is 28 years old and has the CdLS diagnosis. He has extreme skin picking and rashes. He is 200 milligrams of Zoloft a good medication for anxiety causing this, or what medications would you suggest?
Yeah, so that's a good sized dose of Zoloft for kind of anxiety. One thing for skin, so one consideration could be, so for hair picking, for hair pulling, skin picking, sometimes N-acetylcysteine can be helpful. It's used in the general population, but I think it's overall the side effects are not too severe. The side effect profile are not too severe, and it might be worth considering a trial of that medication to see if that addresses the behavior.
Great, thank you. Next question. Do you think that people with CdLS can have leaky guts or yeast issues?
I think so. I think it's probably safe to say in CdLS anything goes. Anything is possible. I think that's probably beyond my expertise to say. But if you could kind of maybe I'll try to kind of guess what you might be getting at, and let me know if this is I'm guessing wrong. But I wonder if you're alluding to kind of the gut-brain connection. And I'll just kind of speak generally to say, yeah, I think there is a brain-gut connection in the sense that in the autism world, there's some literature to suggest that the microbiome environment in the gut may play a role in behavioral symptoms. So the general answer to your question, and forgive me if this is not what you're getting at, is that there can be a gut-brain connection, and there is a possibility that, the microbiome or GI issues may be affecting behavior. And I think that's generally true, meaning that if you have constipation or if you have GI issues like reflux, then behaviors are going to be, there can be challenging behaviors as a result. If you're constipated, you're not feeling well, and if you're not feeling well, you may exhibit, some aggressive behaviors or some irritability and so forth.
Great, thank you. And our last question is, it's hard to understand behaviors and mental illness. If anything, is there any correlations between the two issues?
Right. I think, from my perspective, I view behaviors, mental illness, I think they're all the same. I mean, they're all reflective of brain dysfunction or dysfunction at the central nervous system. I think historically there's been a divide between neurology and psychiatry, but ultimately I think they're manifestations of dysfunction of the same organ, that is the brain. So I think, from my perspective, whether even though quote unquote mental illness may be like schizophrenia or psychosis, and behavior may be like aggression or self-injury, I view both of those features as just different parts of the spectrum of neurodevelopmental, neuropsychiatric brain dysfunction in CdLS. So I think they're part of the same spectrum of neurological / developmental / behavioral issues.
Great, thanks. And we actually have time for one last question. And that is, my son has been clinically diagnosed with CHARGE syndrome, however, shows behaviors associated with CdLS. Is there any benefit to have him genetically tested? He does have a lot of self-hitting, has anxiety and depression.
Right. So CHARGE syndrome can also be associated with challenging behaviors as well. I think what you may be seeing is the fact that challenging behaviors can be an overlapping feature of many different genetic syndromes. So to answer your question, if your child has additional features of CdLS, maybe kind of, or if your child has features that are not explained by the CHARGE syndrome, but which may be explained by the CdLS or by CdLS, or if there's additional evidence that there are problems that may be related to CdLS, then I think it might be worthwhile. It's not unprecedented. There are some kids who have two genetic diagnoses, or two rare genetic diagnoses. In fact, there are even some kids who have 3 or even more rare genetic disorders. So it's not unprecedented to have CHARGE plus another genetic syndrome. But in terms of whether you need to actually get tested for CdLS, it depends on what the specific issues that you're seeing, are these issues that could not be explained by CHARGE? Are there additional features not explained by the CHARGE syndrome that would be explained by a CdLS diagnosis and so forth? So it's really kind of context dependent. But just to kind of reiterate that challenging behaviors in and of themselves are seen across the board in many different genetic syndromes associated with neurodevelopmental disorders.
Great. Thank you so much, Dr. Srivastava, for taking the time to address our questions from our audience. And back to you, Deirdre.
Thanks so much. And thank you, everybody, for joining us today. And hopefully in the future, you may be able to join us with another webinar. Thank you so much, Dr. Srivastava, and taking the time and just sharing your knowledge with us. We appreciate it. Have a great day.
Great. It's my pleasure. Take care.
Thank you.